Hello, my name is Peter Cotton. I'm on the board of SE Healthcare Consulting. We're very interested in quality and safety, and I'm particularly responsible for the sections involving gastroenterology and endoscopy. Recently, I was able to have a conversation with two giants in the digestive endoscopy field, Grace Elter and Greg Ginsberg. They've been leading on our professional society, and I thought it would be interesting to get their spin on where we're at and where we need to go. Grace, you want to start and tell us what ASG has been doing?
I actually think one of the pivotal things in quality endoscopy was the publication in 2006 of the joint ASGE and ACG guidelines on quality indicators for all of our endoscopic procedures. It's a long list of quality indicators, general ones and specific ones to each procedure. In the past, we really hadn't had that. At that time, the leadership of the ASGE and the ACG endorsed that this should be measured by all endoscopy units, whether they be hospital-based or ambulatory surgical units. And I think that was the first time that it really came into everyone's daily practice, that this was something important to measure these quality measures on a regular basis. So to me, that was key.
Well, let's follow on from that. How much has that actually happened? I mean, it all sounds a great idea, but who's doing it?
I think certainly major academic medical centers are measuring quality measures. And there was some of that before, but I think it really has moved forward. The ASG also has tried to get other endoscopy centers, ambulatory endoscopy centers, and other hospitals, other hospital-based units to sign on to their quality endoscopy unit recognition program, which also requires measurement of these various quality metrics. How widespread that is, I don't know. My guess is it's still a minority of the endoscopy performed in the United States.
I think there were about 500 units that signed up for the initial phase of the endoscopy unit recognition program. I wonder how many have actually renewed because it's become a lot tougher. You have to produce a lot of data now. Do you know the answer to that, Craig?
Well, we're just seeing that right now in that the initial appointment was a 3-year appointment, so now we're seeing the process of re-upping, and frankly we're analyzing the percentage of units that are opting to do so. As you indicated, the bar's been set a little bit higher, and we don't have feedback on that right now.
So what's in it for the units? Because some may think it's just not worth their while. What do the units get out of doing that?
Well, that's an excellent question. You know, when we talk about quality in endoscopy, there are a number of facets. There are the facets pertaining to the endoscopist, him or herself, and we know that endoscopy can do an awful lot of good, but we know that poor endoscopy can result in an awful lot of harm, and particularly, you know, just the society being the steward of endoscopy, it is the society's responsibility to ensure that the individuals who are performing endoscopy are well trained and are performing complete and thorough exams in a safe environment. Now, that's where the endoscopy unit recognition program comes into, because it raises the consciousness of all the aspects that are critical to providing quality in terms of the endoscopy environment. You know, not too many weeks or months go by where we don't hear about an incident of infection that occurs in some sort of ambulatory care facility, be it a dental or medical or surgical facility. And so these things are key. Being a member or having your unit certified as a quality endoscopy recognition unit does not make you immune from those trespasses. But the expectation is that you are a unit that has acknowledged all the aspects that are critical to quality within an endoscopy unit. And so the expectation is that you run your unit with a higher level of scrutiny than a unit that would dismiss or be apt to be more dismissive of those.
A skeptic could say that all that this is doing is giving a little badge to people who are already doing a good job. Have we got any evidence that actually the standards have improved even in those units?
Well, the program wasn't developed to report back on evidence to affirm that those units were practicing at a higher level. It is it's a voluntary process, and the expectation is that the units that volunteer towards that are exhibiting a higher level of motivation to ensure those levels of quality. We actually did have to put in a program, not a program, but a plan as to how to respond if and when an endoscopy unit that was part of the recognition program would have a reprocessing error, because anytime you have humans involved, there is going to be the opportunity for human error.
Well, you mentioned that this is recognition of the units, and it's important to recognize the environment as well as the practitioners. So I've been wondering why we don't have some sort of recognition for the endoscopists themselves, and pushing rather naively for some sort of certification, which I know has been discussed up, down and backwards for a long time. But since we need licenses to drive a car or a truck or a train or an airplane, why don't we have a license to drive an endoscope, Grace?
Well, we do have certification to be board certified gastroenterologist, although they don't test us on endoscopic skills. There are, probably at least 10% of the questions on the boards are, centering endoscopic practice, probably more than that, maybe 25%. So it's pretty high. But those are questions that you're answering that are multi-choice answers. They're not endoscopic skills. So you're talking about, two different things. Nobody, I don't think, is really measuring endoscopic skills for certification.
Why not?
Hard to do. And who's going to be the certifying group? The American Board of Internal Medicine, who certifies gastroenterologists, has the money and the means to do so, but I think they think it's going to be very difficult to measure technical skills. I think that they think it's difficult and therefore haven't delved into that.
Right, it's been done in Britain, where I came from originally, when they introduced the colon cancer screening program. To be eligible to participate in that as an endoscopist, you had to pass a driving test for colonoscopy. And that involves spending a day at one hospital that runs that program, had to see a couple of supervised procedures, to answer some questions and to show some logbooks. So it can be done. About 25% of the people who applied to do that, who were established colonoscopists, failed the test. So I'm just wondering why we can't do it at least for the highest risk procedures like ERCP.
I think it could be done. The question is what group is going to do it. The other question is that going to be enforced by credentialing committees or by payers?
Right.
Payers have the ultimate gun, because if the payers say, well, if you're not credentialed as an endoscopist, we're not going to pay for it. Yeah. That's really the only power. Hospital credentialing committees, fairly, I think they're pretty much rubber stamps. They really don't delve into much other than a colleague saying, yes, this person's adequately trained.
Yeah, what can we do about that? Because that does seem to be a slight problem. Greg?
Well, there are several initiatives underway looking at mechanisms by which we can assess levels of skill acquisition and competency. The surgeons have embraced this with their laparoscopic training skills program, and they've incorporated that into matriculation through their surgical training programs. They have developed a program for flexible endoscopy as well. We've are partnering with SAGES and as a liaison to the American Board of Surgery to look at this as to how effectively it can assess certain levels of skills. The reality is it's pretty crude, and it doesn't translate so well to what happens in clinical practice. And it's one thing to be able to drive an endoscope. It's another aspect to most appropriately recognize the appropriate indications for the procedure, the relative risks and benefits, weigh the relative risks and benefits and alternatives, and then the constant reassessment of risk versus benefit to intraprocedurally identify, interpret findings. And so that being said, if we have simulators that can mimic flying a jet airplane, we could similarly develop sufficiently sophisticated simulators that would replicate this as well. The difference is that while the stakes may be as high or higher, there hasn't been a willingness on the part of credentialing agencies or professional societies to fund it and to back it.
I've always thought that the airline pilots were so keen on safety because if there was an accident, they were involved in it, which it doesn't apply to us
right.
individually. The elephant in this discussion is the fact that maybe less than half of all the GI endoscopy done in the United States is done by gastroenterologists whose training is usually pretty good. So there's a whole lot of people out of there doing procedures. We don't know what the quality is. We suspect that some of it is rather poor. So how can we protect the patients from very poor quality endoscopy done by people who are inadequately trained? Grace?
Yeah, I'm not sure it's less than half. At least Medicare data from probably almost 10 years ago now suggested that about 75% of endoscopy was performed by gastroenterologists.
Okay.
Yeah, but still, your point is well taken. A large percent is still done by non-gastroenterologists, and what is their training and what's the quality? And I suspect that's even more variable, and there's some variability even among the GI community. Again, I think that an educated patient population would be one way to protect it. Either that, or you have to take away the financial incentives for local credentialing boards. I mean, it's a financial incentive for a hospital credentialing board to credential someone who does endoscopy in their hospital. And so, you were asking the wrong group.
Right.
When professional societies like the ASGE make efforts to promote the expected higher level of proficiency and quality on the part of their physician memberships, they're immediately tagged as being involved in a turf war.
Right.
And
So what's the status of the discussion with other groups, the surgeons, primary care physicians?
It's in flux, honestly. And what we're trying to use is data. That's the strongest argument. And there always has been some very high quality data looking at, in particularly related to colonoscopy, polyp miss rates, and incident cancer rates that have been consistently higher in non-gastroenterology performed colonoscopy, as that one particular example. And until there are economic mediators that are going to make discriminations to who certain payers will permit to perform colonoscopy based on a particular level of accreditation or certification. I think our free market system is going to continue to support both. As Grace said, this has not been an area where ASG has been able to effectively educate the general public, the patient population, to be able to discriminate between a great endoscopist and an ordinary endoscopist, or a far less.
Well, I was going to come back to that because I've been pushing the idea that we should be educating the patients. What the ASG has done and other societies have pushed the idea of colorectal cancer screening, But I don't see much out there about make sure that your colonoscopist knows what he's doing.
In March being Colorectal Cancer Awareness Month, there is a public relations campaign with a list that they try to get high onto internet searches to what questions to ask your colonoscopist, including are you an ASG member, and what is your adenoma detection rate. So there's a list of 10 questions. That all really point to quality. But that direct-to-consumer education and promotion is very challenging for a small subspecialty society.
Right. Let's come back to the units for a moment, because again, I want to go back to my little British connection, because I'm sure you're aware they have something called the Global Rating Scale in Britain, which is an initiative to basically for endoscopy units to self-assess themselves against established guidelines, which has been in place now for about 7 years and includes 100% of all endoscopy units in the country and has shown a tremendous improvement in at least perceived quality in that period of time. And that same system is being adapted in Canada, in Holland, New Zealand. Has there been any discussion about doing something like that, which is sort of akin to the endoscopy unit recognition program, but it's much broader than that and covers, obviously, people who are not members of professional societies or could?
It seems to me that the difference in the countries that you mentioned is that they're single-payer systems.
Mm-hmm.
And so, again, I think the real power is in the hands of the payer.
Mm-hmm.
And our payer system is so complex. I don't think they have they're not sure what quality is, except for, they know what cost, and so they can go for the cheaper provider, but I'm not sure that they have any idea how to get at quality.
There's a big difference in a voluntary system versus a mandatory system.
Right.
And unless there's either a carrot or a stick, it's hard to imagine that there'll be widespread embracing. The whole pay for performance potential was a major motivator in professional societies developing quality indicators so that we could put our membership in positions where they could financially benefit from demonstrating quality performance.
Right.
Whether or not we'll actually see any of that is probably not likely. There's a stick end to that as well, that if you're not providing certain quality measures, that there'll be reductions in your Medicare reimbursement. So it does right now, unfortunately. The more sophisticated quality measures come at a considerable cost.
Right.
So to enroll in one of the established endoscopy quality measure programs, there's a real substantial financial outlay.
Yeah, let's talk about GI Quick for a moment. GI Quick, as you know, is a voluntary benchmarking tool for colonoscopy. How successful has that initiative been? Have you any idea how many people have signed up for the GI Quick?
Yeah, I don't know the numbers, but this is an opportunity for industry to really be able to make some hay, because if you can do this quickly, inexpensively, and part of matter of fact routine, so that you have automated export of the pertinent data from the electronic procedure report, then that would enable it. Right now, it requires a pretty substantial component of double reporting, and there's a big cost outlay for individual membership.
Yeah, I think that GI Quick hasn't taken on as much as they had hoped, partly because the payers haven't really required it, but also partly because you can accomplish everything GI Quick can at your own institution without paying the fees. So, for instance, at my institution, we measure adenoma detection rate, cecal intubation rate, per provider, and give that data out every 6 months to every provider, what their current data is.
Now, is that an automated system, or is it?
It's pretty well automated. We get, we actually wrote, my IT folks, because our probation did not have it available at that time. We started this 5-6 years ago. Really didn't have a good query of their own database. So we wrote the query that probation bought from our IT department. So they wrote the query that we can get polyp detection with the denominator of screening and surveillance. And then that gives us a list of names and registration numbers for patients. And our hospital quality group, because I'm a big medical center, we have a hospital quality group I can go to, and they have manpower.
Yeah.
They match that against our pathology database.
Yeah, so
And
you
they
still
can-
have to have a handful of humans that go in and.
Well,
do
they
paperwork.
match it by, it's electronic match, and then they give us back our adenoma detection rate. So without that kind of background, though, you're right, to pay for that out of my own unit, it's very easy for us to, now that I have a query, to query probation and say, this is our polyp detection rate for the last 6 months, and then send it to the quality office. The quality office gives me adenoma detection rate. So that's very simple. But then why would I pay money to GI Quick to send that in there? Because I already know what national guidelines are, benchmarks are.
Oh, I think that's
because they're published.
very fair comment. You said that you disseminate this information.
Yes.
When you send it to me as a colonoscopist, do I see everybody else's numbers?
No. Here's what I send. I send, Dr. Cotton, your adenoma detection rate for the last 6 months was 32%, and then we put in parentheses N, that is how many colons you did, because that's highly variable. The overall GI division adenoma detection rate was 43%, and then we put in parentheses the N, and then we do the same for cecal intubation. And every faculty member, we have 55 faculty members who do colonoscopy, gets a 6-month report. What we've seen, we've been doing this now for, I think, 4 years, 5 years, quite a while, is that everybody has improved a little, but we still have a few individuals who are below national.
What do you do about them?
We've done nothing, to be honest.
Oh.
Besides they get the data, and so
Yeah.
they know they're below national guidelines. But the national guidelines aren't all that stringent.
No, they're not, for sure.
It's
No.
25% in
Yeah.
the format, and so.
So has anybody stopped doing procedures when they've seen their data?
No.
I
But
mean,
we
that
have
was-
a couple of people that are below. Our overall division adenoma detection rate right now is running around 35%, so it's very high.
Yeah, but is
and-
that an enriched population, so it's not just average risk screening?
No, it's
patients, right?
anyone whose indication is screening or surveillance,
Okay.
which is what's published.
Yes.
So everyone else is taken out of the denominator, so the IBD surveillance or the rectal bleeding, those are all taken out. It's only screening or surveillance, polyp surveillance. So it's a subset of the total colonoscopies. That's what we had to write the original query on the database. But and then to test that query, when we first set it up, I actually had to go through lots of reports to make sure the query was right. The query is working, and I think our data's solid. The question is, what do you do with a couple low providers? I was very interested in the paper, I think it came from Mayo Jacksonville, that talked about showing videos to people who were not doing well. Was that Mayo Jacksonville?
Well,
It was published
Yeah, it
recently.
was, yes, it
one
was.
paper that I think of is Doug Greck's paper and this seems to be the most effective means to influence behavior when you identify an outlier. That is to let the colonoscopist know that his procedure, his or her colonoscopy is being videotaped and will be reviewed. And you don't tell them which cases they're going to be reviewed, but that has been the most substantial or the most substantive effort to improve surface area of the colon that an individual inspects, and has been associated with the highest rates of improvement in polyp detection.
The paper I'm quoting actually had a program that you had to watch videos and take tests.
Yeah, it was a randomized trial. Actually.
Yeah, it was a
very
randomized
good.
trial. Just reporting to faculty improved everybody's rates.
Right.
So, a little bit. But like I said, we have just a couple people that are below national benchmark guidelines. Almost everyone else is above it. But the national benchmarks aren't that.
And certainly this will
High.
not promote the resect and discard, since you won't have the
Yes, no.
documentation of
Then I would
a
not
small
have it.
adenoma
Right,
detection. Because the reason that people boost their adenoma detection rates is by taking off more small titsels, not necessarily identified.
Well, let's just change direction for the end of this discussion, which I found very interesting, and to ask you what we should be doing in the future. We've heard a good deal about what's been going on and how we got there, but what are the main challenges and how should they be addressed, Grace?
I think the main challenge is we already know what quality indicators are out there. They're just not widely adhered to or practiced or measured.
Mm-hmm.
So to me, the challenge is to get all endoscopists, all endoscopy units, whether they're hospital-based or not, to start measuring these quality
And what's the
measures.
motivation for them? What's the
I
incentive?
think it's got to be the payers. I think it's the only way. I don't know. What are your thoughts?
Well, I actually do believe that we will see an emergence of certification for different aspects of endoscopy. And I think it's justified in the context of what we've discussed. I think that we have ample evidence that historically colonoscopy has underperformed, particularly in the prevention of right-side colon cancers. In part, that's because there's been an evolution in colorectal cancer biology in the United States, but it's requiring a re-education in terms of lesion recognition, detection, and management. And so it requires an effort at retraining education. And I think if we're going to invest in training education, we ought to ensure that we're having that's being effective. And I think a certification process is going to be part of it.
Well, as we said, the ASG has put together a recognition program for units. Why can't it just go ahead and set up a recognition program for certain types of endoscopists, so that you can say, I've got an ASG badge, they say that I've done all the right things in training and I'm measuring my performance and it's good.
This is ASG is piloting a program to do just that.
Oh.
We're going to start off with small steps, particularly as it pertains to endoscopic mucosal resection, and but I expect it to expand beyond that.
Oh, that's
You know,
nice.
as you know, Peter, in the United States, physicians have been fiercely independent, and there are only 6,000 U.S. members of the ASG. There are many more people out there performing colonoscopy, and so we have to, as a professional society, we want to be the stewards of the profession. At the same time, we want to ensure the highest quality among the membership, but we don't want to alienate the membership either. And so it is a process. It's not something that you can flick a switch on overnight.
Does industry have any responsibility in this regard? I mean, should they actually issue a sort of health warning with each instrument that they sell? Or?
In my opinion, industry is tremendously invested in this, because if you have competing technologies, if you can't show that colonoscopy is much, much better than CT colonography or fit testing, then that should cut into your bottom line. So I think industry has a big responsibility towards this. That's why it's really important that they support these initiatives on the part of the professional societies.
That's interesting. I sort of think of just the opposite, that industry, their business, they're selling equipment, and are they responsible for how that equipment, it's like if you're selling a car, you're responsible for the person being a good driver. I'm not sure of that.
Or a gun?
Yeah, I'm not sure of that.
Well, you have to, automobiles have to have certain safety and quality performance measures.
Yeah, the drivers have to have a license, or at least theoretically, and some insurance to go with it. Any final comments on the quality safety issue? As you said, Greg, correctly, digestive endoscopy has had enormous benefits, but there's still people who are being seriously hurt by it.
I think we could do a better job, and I think elevating quality across the board is going to be a critical component of that, and it's going to be increasingly important in an increasingly competitive healthcare environment. I think people that have data to show that they are providing quality are going to be in an advantageous position.
I hope so. Right now, I don't think the public, even educated public, really understands that. They want to go, to the person they like, and, you know, has a good bedside manner, more than they're concerned about quality right now.
Well, that was interesting. Thanks to Grace and Greg and for all of those who've been watching. There's more information on this topic on our website, and I'd be happy to receive an email from anybody who wants to follow up on some of the details.